Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And as I usually tell you, there are always a lot of health topics, but one of the top three is always cardiac disease, cardiovascular disease. And there's been so many new innovative techniques and applications of clinical service to cardiac care that I figured I want to bring some experts here. So we have experts. Sitting in front of me is a cardiothoracic surgeon, Dr. Eric Beyer. And Dr. Beyer has been practicing in the community for quite a while. Welcome, Dr. Beyer.
Thank you.
Good to have you here.
Thanks for having me.
And David Kenigsberg.
Thanks for having me.
Wait a minute, I got to tell the people who you are. Not only do you heart rhythm specialist, but you tell them what an electrophysiologist is.
Sure. So I'm a clinical cardiac electrophysiologist, which means that I trained in medicine and cardiology and then did the subspecialty of cardiac electrophysiology. It deals in the treatment and diagnosis of heart rhythm disorders. And I put in pacemakers, defibrillators, and do ablations on arrhythmias. And I spend the majority of my time dealing with my favorite arrhythmia, atrial fibrillation. And Eric and I work together hand in hand in complex arrhythmia ablation when it becomes a hybrid procedure between a catheter-based procedure, which is what I do, and a surgical procedure, which is what Eric does.
Right.
So we work hand in hand quite frequently for the more complex cases.
And let me just stick with you, Dr. Kenigsberg, for a minute. Because, you know, we've had the folks out there ask some very good questions, and that's why we have you here. And they know of a lot of the work that someone like yourself does. And we've been talking for quite a while with colleagues of yours over the last couple of years about the use of shall we say, minimally invasive procedures by using stents and ablation and things of that nature, which in a sense has taken some of the responsibilities away from the actual cardiovascular surgical procedures. But I'd like you to explain to the folks what an ablation is and what stents are.
Sure. So the way I mostly tell my patients that they can clearly understand in lay terms is there are two types of cardiology subspecialties. There are the ones that are plumbers, and then there are the ones that are electricians. I'm an electrician, so I deal with heart rhythm disorders and the electrical system of the heart and any ailment that relates to that. The interventional cardiologists, those are the plumbers, and they deal with putting in stents and doing diagnostic caths and measuring the pressures in the heart, assessing valvular disease, and so forth. So, and at the end of cardiology fellowship, we kind of take two different paths, and I took the electrical path. The thing that I really love about electrophysiology, and the reason I went into it, is because electrophysiology is a rare field where you can really take what you learn at the bench, meaning in the science lab, and take it to the patient. We have lots of disease states where we know the genetics, we know which protein is abnormal, and then we can treat a patient. For instance, a rare cause of sudden cardiac death called Brugada syndrome. So we know that this is an abnormality of a gene that's the SCN5A gene, and we also know that those patients die in the middle of the night. There is an 8-to-1 male to female predominance, and those patients usually need defibrillators to protect them from sudden cardiac death. So that's the thing that got me into electrophysiology. The other thing about electrophysiology that's unique or interesting is that not only can we think about all these ailments and delve into them and read EKGs for hours on end, but we can also do procedures to help patients. So I think in that regard, it's a very unique and rewarding field. What's also interesting is I've always loved working with cardiothoracic surgeons. Before I went to med school, I spent months in the OR watching a cardiothoracic surgeon at the old Miami Heart Institute, and Malcolm Dorman. And I really enjoyed the time there, and I felt it was really interesting to be able to be in that environment. And coming back to my current state in my career, I enjoy going into the OR with Eric because they have direct visualization of the heart. And just the other day, we did a case where we saw where the scar was in the heart in a patient who had recurrent ventricular arrhythmias, and we were able to visualize it and then ablate it. And I saw that gentleman yesterday. He hasn't had any more ventricular tachycardia since we did that joint procedure together.
Well, that's great. So, Dr. Bayer, here we are. You're no longer, you're not the plumber, all right? And you're not the electrician. You're really the landlord. That's what you are, because the plumber and electrician do their work, but all of a sudden they got to call the landlord because the landlord is, he's got the keys. That's sort of a metaphorical relationship. But tell us about today. There's such a difference today, and I'm sure that over the years as you've evolved within your own subspecialty, there's been so many changes relative to minimally invasive, I guess you could say, applications and things of that nature. So talk to us about cardiovascular surgery.
Yeah, I would agree. It's incredible how many changes have just taken place in my short career. I've only been out practicing cardiac surgery for about 12 years now. And of course, it took 10 years to after medical school to get to that point. But in just that short time frame, there's been incredible advances, and particularly in arrhythmia surgery and ablation technologies. It's been very rapid how we've changed from going from mainly doing open surgeries that were very invasive, dividing the sternum and doing what's called a Cox-Maze procedure on patients, and it was only applicable to a few patients in that subgroup because a lot of people would not submit themselves to performing, having surgery performed on them in that manner. And to where we're now treating, and David is treating arrhythmias, by taking a patient and ablating through their femoral vein into their heart and stopping these arrhythmias, and these patients are going home that day or the next day. So it's been a very dramatic advancement over the last decade or so in what we're seeing. But it's also nice to see that we're actually coming together more. Heart surgery used to be very separate from cardiology. And, I appreciate the landlord analogy. I don't know if I would describe it as such, but I think what we're doing is more coming together as a specialty than having very distinct separate entities. And you'll see Dr. Kenningsberg and I will talk about patients and come up with a game plan that works best for the patient. And whether that means doing an open procedure or a closed procedure on them, that's really what it boils down to. It's what is best for the patient. And this level of communication has gotten better over the years, and it's just fantastic. Now, I learn a lot from David, and I hope he learns a little bit from me. But it's nice having that kind of collegial relationship.
We do work together in the hybrid OR, and that is the multi-specialty OR. And it does allow for a lot of things. It allows for me to use fluoroscopy, intracardiac echocardiography, my 3D electroanatomical mapping tools, a pacing and recording system, and it's an OR. So all the things that a surgeon needs are readily available to him as well. It's a vast space, so there's room for all the equipment we need. The table moves in multiple planes and directions. The screens move around. The entire team is available. So that has really allowed our fields to kind of merge and evolve, as you've mentioned. And at the end of the day, you're right, the benefit is to the patient, which is why we all do this. The other thing you asked before was to define the term ablation, because I use that every day with people, with lay people, and assume everyone knows what it means. But ablation in general terms means to destroy tissue with energy. And in my field, historically, it's used radio frequency energy, which is akin to microwaving tissue. And so we put a catheter. It typically has between a 3.5 millimeter to an 8 millimeter tip. We put it in the heart, find the focus that's abnormal, stay away from areas that are normal conduction, the normal wiring of the heart, and then turn on radiofrequency energy and destroy it. The benefit in that is it's almost instantaneous that that focus gets destroyed. That also could be a drawback if you're in the wrong location or you're worried about collateral damage. This technology has been available in surgery for a while, but about 5 years ago, we started using cryothermal energy more frequently in my field, in electrophysiology. And nowadays, for patients who have atrial fibrillation, which is an irregular rhythm of the heart, the most common arrhythmia, the arrhythmia that about a quarter of the population will get if we live long enough. That arrhythmia used to be treated only with radiofrequency energy. Now we go into the heart, through the leg, through a small needle stick, with a tube in the leg, up into the heart, make a small needle stick in the heart, go over to the left side of the heart, and then do the ablation procedure with a balloon. And so we know that the atrial fibrillation, this abnormal rhythm, comes from the pulmonary veins, which are the veins that bring the blood from the lungs back into the heart with oxygen. And those veins are a conduit, and they really should have no electrical activity. But the abnormal electrical activity has been found to cause the atrial fibrillation. So we blow up this balloon and we electrically isolate those 4 pulmonary veins, and that cures a large percentage of patients with early atrial fibrillation. Now, when they've had atrial fibrillation for many years, they have big hearts, they have other problems, that's when we need to work together with multiple modalities, multiple tools, catheters, surgery, in concert to treat those patients.
And those modalities are constantly evolving. As you know, as we communicate with each other, we bounce ideas off each other, and these ideas then translate into action, where we actually will change the way we're performing the procedures. And even nowadays they're doing procedures called convergent mazes, and those are for the patients that are in long-term AFib, that are kind of in AFib constantly, and their atrium are dilated. And so there's an opportunity for a surgeon and EP to get together and perform this hybrid procedure. And that procedure is gaining traction now. There's other procedures that are hybrid approaches that are on the horizon as well. But it's fascinating, all this technology, how it comes together, and how we are constantly evolving for the patient's sake. They're the driving force behind what we're doing. So.
Well, and again, that's why I said to both of you before the show, the ideas for these shows come from the folks that are viewing. And it's amazing to me that, years ago, I used to say this early on in our career here, we were going into our 17th year of the show, when we used to talk about Reader's Digest. No, I don't even know whether there is a Reader's Digest anymore. Reader's Digest, knowledge. People would get these short little snippets, and they would get this information. But now everybody gets this information on the computer, and they get these little snippets. And I always tell these folks, please, please, communicate with your physicians. Communicate with your primary care physician. Let the primary care physician talk to the subspecialist. Make sure you do that, because there's so much opportunity now because of the collegiality of not only personalities, but knowledge, which is much more important. I mean, you don't have to like everybody, but you certainly have to know something that is correct and what is incorrect. And what's valuable to them is the ability of people like yourselves communicating, and then it being translated into what? Quality of life for the people that are viewing, who are asking these questions. That's really what it's all about. Let me get back to you, Dr. Kenigsberg.
So another way we work together closely, which is interesting, is I enjoy putting in devices. I put in pacemakers, I put in defibrillators. These are life-saving therapies. There's actually some very interesting innovation in that field that we could talk about. But sometimes those leads, which are man-made, fail. They crack, they fracture, the tubing around them fractures, the cable itself fractures, or patients develop infections. And in that situation, we have to take them out. For a lead that's been in for a month, a week, 6 months, it usually just, you unscrew it and it comes out. But for leads that have been in for longer than that, we usually have to use a laser to lace that out of the scar tissue from the chest, either on the right or the left side, usually in the left side, all the way into the heart. And so that's when we work together, because if I push too hard, I can make a big hole in the heart or in one of the vascular portions on its way to the heart, the vena cava or so forth. And I need Eric's help on the spot to be able to sew things up. Now, thank God we haven't had to do that, but it's always good to be able to have that opportunity to save a patient when it needs to be done. So that's how we started working together. And over time, that's also evolved into the ablation work, which is really the cutting edge stuff that's happening in very few centers around the world.
No question. But it is permeating the profession. There's no question about it. Let me ask you a question about these devices that are implanted. I know because of computerization, satellite technique, communications, et cetera, that a lot of an instant communication is brought to the medical professional that is part of the monitoring process.
Absolutely.
Let's talk a bit about that.
Sure. So the concept of remote monitoring was started a number of years ago, where basically a patient would put a little device that looked like a mouse over the pacemaker itself, and that information would get sent via phone line to a call center, and that would get to the doctor's office. Today, almost all devices inside of the header of the device has a radio frequency antenna. That antenna talks to a device that sits by the bed of the patient, usually in the middle of the night, and uploads information to the physician pretty much real time. Now, I basically say it's Big Brother, because Big Brother's watching all the time if there's a problem. If there's a problem, it will alert me. If there's no problem, it does absolutely nothing. So patients who come and follow with their cardiologist or the implanting electrophysiologist usually come to the office now twice a year. And then the rest of the time, we're monitoring them remotely. And if there's an issue, we bring them in. What are the issues? The issues are new onset of arrhythmia, which before we couldn't detect until they came to the office. Any lead malfunction, any device malfunction, which are rare but possible and could be life-threatening. Life-threatening or dangerous arrhythmias. And what's very interesting and important are any signs of heart failure. We can now monitor for fluid across the lung cavity to be able to tell if there's a change in impedance that would signify fluid on the lungs, and that would signify the patient should come in. And that usually precedes congestive heart failure symptoms. So monitoring has really taken off. In my practice, we're 4 electrophysiologists. We cover most of Broward County. We have a very large home monitoring program in our practice with all the major device companies. There are 5 companies. And we try to get every patient on remote monitoring because it really is a safety net for any problems that could occur in between doctor visits.
I had a member of my family just recently went on a vacation young person, to Las Vegas, and didn't recognize, for some reason, that he was being dehydrated dramatically, and his pacemaker immediately made whatever satellite communication know that he was having trouble. Anyway, long story short, he ended up in the ER, and they rebalanced his rhythm but he flew back home to be ablated. That was it. But just think of what the difference is today, from a little mouse to talking to a telephone and then trying to reach whoever. Now it's you got these monitoring entities that are there to make sure that these folks that are right here are living with the very best of of your knowledge. That's really what it's all
Yeah,
about.
this is what's amazing to me. It's this technology merging with with our specialties. It's just phenomenal when you hear something like this. I think even Dick Cheney, though, didn't he have an AICD in? And
Yes.
my understanding is the electrophysiologist turned off the ability for anybody to analyze the AICD remotely. Just because he was such a high-profile figure, and so these are, all these questions start coming up, but it's all fascinating to me. It's very interesting how this technology is there for the patients and just improves everybody's lives. And I can't even imagine what the next 10 years will hold for us, because it's just constantly changing. And when we bring in these kind of new technologies, what's going to come?
Well, the excitement, again, to the folks that are viewing, is the fact that, because they understand, when I say understand, they don't understand the composite nature of what creates technology, but they utilize technology all the time. Just
Yes.
sitting there in front of television, doing this and doing that, and recording and going back and et cetera. It's technology, but it's an application of technology, which is not much different than the technology that you use.
Absolutely. I just wanted to mention there is a very late breakthrough in pacemaker technology. So it used to be that we would have to implant leads. And I mentioned before, the problem with leads is sometimes we have to take them out, and that becomes an issue. We have now a device that can be deployed through the groin directly into the heart without any leads. It kind of looks like a bullet that can be screwed into the heart directly, and that device functions on its own as a pacemaker for about 10 to 12 years. And if you need another one, we could put another one in. So very new technology, very primitive technology as far as its ability. It's only a 1-lead system. It's not a 2-lead or a 3-lead system. It's not a defibrillator. It can't really communicate with other systems yet, but a major breakthrough in the sense that we don't have to put in leads from the chest anymore. We can put the device directly into the heart, basically due to miniaturization and computer technology that has advanced quite a bit.
Absolutely.
So you can see, beforehand, remember when surgeons would put big patches
Yeah.
on the heart? This was a little before my time. I was able to see a few of these, but they would have to open a chest up, put a huge patch on the heart, and now we're moving into these kind of technologies. And I don't know if you want to elaborate a little bit on the Watchman device too.
Sure.
There's another device that's coming up. That's
We'd like
fascinating.
to, but believe it or not, we're down to the last 2 minutes of this show. You guys,
Time flies when you're having fun.
my doctors in front of me, Dr. Beyer and Dr. Kenigsberg, I appreciate what you're bringing to the knowledge of our viewers. There's a lot more. We're going to bring you back at some point in time, because I'll guarantee you 6 months from now there's going to be a new advance. But I think it's of tremendous interest. Like I said, the people pick up things. They pick up knowledge, which is not complete. And what we try to do is we try to fill in the spaces, because they ask these questions all the time. And all they care about, you got to remember, Florida is a very interesting state. We have a huge percentage of our population above the age of 70, and even larger, the largest percentage of our population over age 80 of any state in the union. So in essence, they're the survivors, and they want the quality of life that they deserve. And it's people like yourself, qualified physicians. Although it's, cardiovascular disease is a disease of the entire spectrum of age. But they're very interested, and I'm very pleased that both of you are here today. And before we do anything, I got to know, where can people reach you, Dr.
Sure.
Kenigsberg?
So I have 4 offices in town. Right. My closest office is here in Plantation.
Right.
And I have an office in the east side of town, 2 blocks south of Holy Cross. I have an office on Northwest Campus and an office on FMC Campus. So my group and I are readily available anywhere here in Broward County.
Anytime there's got to be a referral, the primary care physicians know how to reach you, right?
Yes.
And Dr. Ray?
Yeah, so the same goes for me. And I have two offices. One's at FMC
Right.
here in Fort Lauderdale, and then the other one's in Delray
Right.
at the Delray Medical Center. But if anybody's ever interested, I have a YouTube channel that has some of these procedures on it. It's if you just look up YouTube and Eric Beyer, you can actually see some of these videos, and there's some contact information.
We
there.
never qualm. We have no qualms about competition at all. So you just keep on going. Well, folks, we wanted to bring this information to you. You asked questions about cardiovascular disease, and really you dominantly about minimally invasive procedures. But what you just heard are really the application of multiple minimally invasive as well as new technology procedures. So you got to remember that Dr. Koenigsberg, who is a cardiac electrophysiologist and a heart rhythm specialist, is the kind of answer to a lot of your questions. He's presented information. So I hope that it's been very valuable. And thank you, Dr. Koenigsberg.
My pleasure. Thank you.
Appreciate it. And Dr. Beyer, cardiovascular surgeons are very important people, but they're even much more important now that we have colleagues sitting in hybrid ORs, because your value is enhanced dramatically by your colleagues who present information that only you can deal with.
Thank you. That was very nice.
Well, thank you very much for being here. As I said to you before, take good care of yourself. If you have any questions or you want any answers, there's an email address and a telephone number right here. And remember, this show is called Dateline Health. We come to you from Nova Southeastern University. And until next time, my name is Fred Lippman. See ya.